Hi guys, Caitlin here, and I'm going to be presenting my clinical teaching project for PC711 Spring 2019. Get everything pulled up here. So I am presenting on the Edinburgh Postnatal Depression Screening. Know it, use it, chart it. So for my needs assessment, postpartum depression, also known as, or shortened for PPD, is a common complication after the birth of a baby. It happens in many women, and many women feel empty or sad after delivery, but these feelings usually subside in 3 to 5 days. If the baby blues don't go away, if you feel sad, hopeless, or empty for longer than 2 weeks, you may have postpartum depression. It is one of the most common complications after delivery. Many women are afraid to report the symptoms because of shame and social stigmas associated with it, so it's frequently underdiagnosed and undertreated. Evidence is showing that maternal-newborn bonding and attachment are impaired in cases where the mother is not treated for postpartum depression. So postpartum depression can affect the mother and the child throughout their childhood, causing delays in language development, problems learning, problems with bonding, behavioral problems, more crying or agitation, shorter heights and higher risk of obesity in preschoolers, and problems dealing with stress and adjusting to school and other social situations. So a formal survey was conducted at an FQHC in Harlingen, Texas, of all licensed practical nurses and medical assistants. The survey was anonymous, and participants were encouraged to be as honest as possible. Of all the 12 nursing staff that were polled, 8 out of 12 knew what the EPDS was. Half knew when to give it to patients. 10 out of 12 could name 5 symptoms of depression, and 8 out of 12 knew what score prompted a further evaluation by a provider and a referral for behavioral wellness services. The reason that I chose to do this as my project is we have a high risk for postpartum depression in this community. There are many social barriers to health, including low income, low resource, low education attainment. We have a high prevalence of teen pregnancies and single mothers. Most of the moms we care for have all of these or a lot of the risk factors for postpartum depression. And these are just a few, and then a few more include personal history of depression, not a good support system from family and friends, problems with the previous pregnancy or birth, relationship or money problems, which goes back to our low income, low resource. Are younger than 20, we have a high prevalence of teen pregnancies, and this goes back to the low education attainment as well. Difficulty breastfeeding, and then we have a lot of unplanned and unwanted pregnancies. I do believe that better and more consistent screening and interventions could help make a large impact in the mental health of this patient population. As far as my learner demographics, they're here posted. My audience is all female in their middle to late 30s. They have all completed some college in the last several years and are familiar with the EMR, or electronic medical record. Almost all of them speak English and Spanish. And then they have all been employed by the clinic for a minimum of 2 years, but the average length of employment is 15 years. The cultural considerations were going to be my biggest barrier for this project. The culture of the Hispanic culture tends to be kind of toughen up buttercup, and they don't talk about a lot of mental health issues. A lot of people know the saying in Spanish, it's la ropa sucio se lava en casa, which generally translates to don't air your dirty laundry in public. The Latino community tends to be very private, and they don't want to talk about public challenges at home, and they certainly don't talk about mental health issues. So they don't seek treatment. They tend to just kind of bury it and think it'll get better, and then it tends not to. And then a lot of them tend to be uninsured or underinsured, so they don't have health insurance and they don't know where to access resources if they did want to. There's also the lack of information within the Hispanic community on mental illness has created a really strong stigma, and many Latinos don't seek treatment because they fear being labeled as locos or crazy. So this causes them shame. It shames their family, and family is a very big pillar in their culture. So they don't want to do anything that would shame them or shame their family. My goals and objectives are listed here. My main goal was just to make sure that everyone was familiar with the EPDS, they knew who to give it to, and then how to document the findings in an electronic medical record, and then also when to refer. So I was doing follow-ups 1 week, 2 week, 3 weeks, and then 3 months following our educational session. My objectives, the first one, I want them to be able to give me 3 common signs of postpartum depression that they need to be looking for and assessing our moms for when they come in. Objective number 2 is that I wanted them to accurately categorize 3 simulated EPDS scores as needing referral or not. And then my third objective was I wanted them to be able to demonstrate correct calculation of the scores and documentation in our EMR, and then identify scores that require notification or not. My instruction method is going to include these 4 methods. I plan to use several different mediums for instruction. This offers my participants a wide variety of learning opportunities and can help with retention of information. As far as my literature review, I found 4 really, really awesome articles. The first one by Clavisi, Gatlin, Cheese, and Strebel was a case study. I think it was a doctoral project. So it's a level 5 on the evidence hierarchy pyramid. And they, kind of very similar to my clinical teaching project, they implemented the EPDS in a clinic setting. The learners were all women's health providers, MDs, and nurse practitioners. They provided the providers with a pretest, development of the EPDS box and a flag in their electronic medical record, and then an educational in-service, and then a post-test. Before the in-service, they gave them a pretest, and it was administered anonymously as well. And then they had a 1-hour educational in-service that was conducted with all the providers. So during the in-service, they were given, the significance of it, the consequences associated with it, and then instructions and directions on how to use the EPDS, how to use it correctly, and how to make sure it gets into the EMR correctly. As far as their results were really impressive. Their screening rates went from 56 to 92%, which is a huge jump, which is awesome for this clinic. It increased understanding of the symptoms related to postpartum depression. So all of the providers self-reported in the post-test that they felt that they understood postpartum depression better and understood the symptoms and kind of the bigger picture of it and how it affects not only the mothers, but also the babies as well. My second article by Aru, Ruiz de la Garia, Zanandonio, and Hoyo Silerio was the effect of PBL teaching method on learning about nursing care for patients with depression. So this was a level 2. This was a quasi-experimental study. And what they did was they implemented a new teaching strategy in third-year nursing students taking mental health courses. There were 2 different groups, a control group who received traditional learning in lecture format, and then an experimental group who received the PBL model of instruction. So the PBL model is very interesting. It allows students to learn about problems that are very similar to the ones that would arise in their real professional lives, so in their real nursing career. And then they're confronted with these problems and forced to analyze the solutions and make, a care plan and collaborate professionally and cross-discipline to work on teamwork and planning and communication to develop a plan for this case study or for this fake patient that they have. All of these skills, the cross-disciplinary competencies and the communication and teamwork, tend to be skills that are frequently underdeveloped among university graduates. As far as their results, so the declarative knowledge increased in both the control and the experimental group, and declarative knowledge was defined as factual knowledge. So this is facts and signs and symptoms and numbers and normal values and all of those things. But what was amazing was their argumentative knowledge increased significantly in the experimental group. So argumentative knowledge is understood as having supporting statements with reasons. So that's the students had to explain the nursing care intervention and justify it with evidence-based data. So it's not just we do A, B, and C, but we do A, B, and C, and this is why we do A, B, and C. So with this teaching learning strategy, the student is obligated to explain all of the reasons for their interventions, and then consequently, they achieved a deeper understanding from everything that they learned. So this was really, really, I mean, this is awesome that they implemented this and had such great results. The third article is the Morgan article. They used seminars as teaching methods for undergraduate nursing education. It was a level 5 on the evidence hierarchy pyramid. It was a quality improvement project. A quick summary, the researchers used seminar sessions of 120 students in year 1 classes that were broken into smaller groups of 7 to 8 people. They employed a variety of learning methods to engage the students, and then each group presented a poster following the seminar session. So their whole argument was that if they engage students in a variety of student-centered activities, it helps them become more informed and self-motivated and curious learners. The teaching methods that they employed were discussion, group work, independent learning, a heavy reliance on technology, building self-confidence, and problem-solving approaches. And then they also did a lot of reflection techniques as well. As far as their results, the use of seminars and the multitude of learning platforms developed the students' ability and enhanced comprehension of the topics. So the students developed their self-confidence. They used a lot of discussion, a lot of group work, a lot of problem solving. And then the students reported that they took great pleasure in being able to utilize the different learning techniques. After they finished, the students' evaluations were very, very positive of the class and the use of the multitude of learning platforms. And for this is why I'm doing a provider or a presenter evaluation, but it's important that lecturers use feedback to develop teaching and facilitation and feedback skills, because it's lifelong learning for all of us, for me as a presenter, for them as a presenter, and then for all of the students. My last and final article was the Hadid article, Pinfold, Ford, Walsh, and Tiley. It was published in the International Journal of Nursing in 2018, and they took, it was a level 2 on the evidence hierarchy. It was a cluster randomized controlled study, kind of a small study, but they took 146 nurses from several London schools, and they were selected to get training on depression through electronic mediums, handouts, and in-person lectures. The goal of this was to improve the nurses' recognition, knowledge, and attitudes regarding depression. As far as their results, after the 3 months were done, 115 nurses had completed all of the outcome measures. And then the training was associated with a significant improvement in the specificity of depression judgment. The nurses also felt more confident about diagnosing depression and their knowledge around depression. And finally, their confidence in their professional role in relation to depression also increased. Another significant change was the optimism about depression outcomes. So when everyone went into this, they kind of had this depression treatment doesn't work. They're going to be depressed forever. But once they did all of this, they realized that if you do get the people who have this the right care and support and resources that they need, that they actually can get better. So the nurses had a lot more optimism, and then were in turn a lot more optimistic with their patients in terms of, hey, you may have this, but we can help. And then they did a 9-month follow-up, and all of the specificity and depression identification and knowledge were maintained. So they had a long-term follow-up there. As far as my synopsis, so the two articles that focused on the depression training was the Clavisi article and then the Haddad article. They both concluded that when education on signs and symptoms of depression and training is implemented for depression screening, positive outcomes were achieved. So if you teach people about depression and how to recognize it, they remember, and they're going to be able to recognize it more easily. And then the screening rates were improved for the healthcare professionals, and the healthcare professionals all felt better equipped to recognize, to screen for, and to treat depression. When you go in knowing, I feel confident about my diagnosis and I feel confident I know how to help you, patients have better outcomes. The Morgan and Aru article were in agreement about implementing similar teaching methods to achieve better learning and comprehension. The PBL method and the seminars used in both of these studies increased the knowledge in their respective cohorts and gained deeper understanding from all of the students. So my review synopsis continued. So nurses learning about depression through connectivism. All the articles I read through really solidified my decision to use connectivism as my teaching method. The Morgan article used seminars to increase the students' knowledge and student satisfaction with the learning process. The seminars employed several different methods for instruction: electronic medium, student collaboration, lectures, group work, and they were all used to help increase the students' depth of knowledge into the subject. The Aru article was even more interesting. They used a PBL method of instructions, and they were not taught in lecture format. They were given a case study and told, research it, find a plan, collaborate, and discover the best solution. They were encouraged to disagree and to have constructive criticism among themselves, which I think is probably the most similar to how healthcare works in the real world. Connectivism encompasses all of these aspects and seeks to further knowledge through all of the access we have to internet and technology. It's easy to implement. So in today's world, we have 24/7 access to information, and I want to encourage my students to take advantage of all the information out there. This is also very easy to implement because everyone has access, either at work, home, or sometimes both, to the internet. The cost is minimal to engage with the internet resources, which is another perk of using this facility. The Clavisi article, which had screening rates increased from 56 to 92%, further proves that this is an easy change to implement in a practice and in a learning setting to get awesome results. So connectivism and the modern student. So connectivism is a great teaching theory for modern students and teaching subjects that have a heavy presence on social media and a large online database for information. The topic of depression is widely discussed, and there's a wealth of knowledge and the ability to connect to others around the world about it. This gives us a chance to change lives. Teaching this topic allows for life-changing intervention to be made universally available to all patients. Students who find a passion in this can connect through the many websites and online support groups focused on this topic. By the time the session is concluded, my goal is to inspire change in all the participants and hopefully ignite a passion in some to continue this work. And the internet and social media are filled with resources that can help students engage continuously with this. So why connectivism? Healthcare is computer-based. Everything's computer-based. I'm on the computer all day, every day. All of our charting is done electronically. Most of our resources and everything are all electronic these days. So it just makes sense to be able to really play on connectivism. The project is taught on a computer-based medium with several different platforms. So I'm using the electronic medical record, I'm using PowerPoint, I'm using video, I'm using Twitter and Instagram to show and how all this is connected. My audience is younger, so these are people who grew up with computers. These are people who, had iPads and cell phones and have always had a computer. So they're really receptive to being taught on a computer-based medium. And then the nature of socialization is evidence of connectiveness. We're all always connected. Everyone has their phone out all the time. Everyone has Twitter up and Facebook and Instagram. And so this allows for a lot of collaboration between all the learners and between learners and new information out there. This also allows the learner to reflect through conversation and interaction, creation and sharing of meaningful digital artifacts. So those are things like blogs, Twitter posts, Instagram posts, Facebook, YouTube Live, stuff like that. And then this also allows for long-term access and engagement on the topic. So you don't have to go running and looking for that one textbook that you left somewhere or that you sold and you want to look something up. It's always there. It's always on the internet. You have your phone, pull it up, pull it out, and read it, okay? As far as the outline of me teaching content, my PowerPoint slides and the videos and the other mediums I'm going to use are all centered on my 3 objectives. So the first objective I'm covering for them is the list 3 common signs and symptoms of depression. So my content's listed here, and then I'm going to open with a video. It's about a lot of postpartum depression moms who are also celebrities. So it's kind of relatable, and it kind of puts a face and a famous face with this depression and takes a little bit of the stigma off of it. And then I'll have the Caitlin-PC articles will be kind of where I'm using my focus for teaching the EPDS tool refresher and the signs and symptoms of depression. And then how it affects maternal and newborn bonding. I have an adjunct article from Women's Health in 2019 that I will be using. For my second objective, I'm going to start out with instructor designed, meaning I will design case simulations for them. It'll be just running through PowerPoints. The Caitlin-PC article is how I'm going to formulate how to score the EPDS, the cutoffs for referral, and then follow-up and screening protocols. I'll be using a handout, PowerPoint slides, and then slides, screenshots of our EMR, and then they will also be working through the EMR as well at the same time. My third objective is the correct calculation and documentation of the EPDS score. So for this, I'm using instructor-designed case simulation. So I'm taking out all the HIPAA information off of real case studies that I have collected over the past several weeks. And we're going to run through them. And these are real patients that we've seen in our practice. So we'll be doing case simulations, EPDS practice with handouts, and then in the EMR live through our test EMR system. And then what scores require immediate action. So they'll be doing EMR hands-on practice for going in and putting in all the numbers, getting the score calculated, verifying it's right, and then going through how to create a referral and how to notify the provider. As far as towards the end, I will be issuing a post-test because I want to assess competency on both ends, prior and after the lecture and the presentation. So we'll be doing a post-session test with simulated patients, and then I will have chart reviews at 1 week, 2 weeks, and 3 weeks, and then 3 months post-session to evaluate long-term learning. And then I have 2 nurses and 1 provider designated as, quote, super users to assist with the electronic medical record entry and then correct referral process. These are just some examples of some of the questions I'm going to have on the learner evaluation. So they have to name some symptoms of depression. Patient JJ is going to come in for her 12-day postpartum and then her 6-week postpartum visit, and they're going to have to say what they would do with what her scores are. And then patient AK kind of throws them for a loop because she has a known history of depression. So I want to see if they were paying attention and how that is going to change their management of what her EPDS score is. As far as evaluating me, I will have a small survey post-session to evaluate the class. I want it to be anonymous because I want them to be very honest with me about it. I don't want them to think that there's going to be repercussions if they say they hated everything. So these are some of the examples of the questions that I will have for them. And I think the most important one tends to be, what would you improve if you taught the class? How could I have done it better? You know, I think that really tends to be the most insightful. So my additional resources, all of the people who come to the educational session will have a printout with all of these resources on them, and they will also be pinned to all of the desktops in our computer, at our computer workstations in our clinic. These are all postpartum depression resources. So some of these are for families, some of these are for healthcare providers, and they're more healthcare provider focused. But a lot of these have resources and who to contact and how to find local resources if we don't have it. And then the signs and symptoms and handouts and stuff like that for the patients to be able to get, for them to get to their family members, and for the nurses to be able to kind of refresh, like, oh wait, what was that thing again? Or is that a symptom of it? I can't remember. So these will be all pinned to their desktop for very easy access. These are my references that I used. My 3 articles, and then the video, and then the article from Women's Health. So that was it. I hope you guys really liked it. This is a very fun project to do, and I can't wait to actually implement it in my clinic.